Next, Douglas Weaver and Dr. Mihai Gheorgiade, professor of medicine at the Northwestern University in Chicago, Illinois, discuss persisting hypotension.
Mihai, welcome to ACCEL.
Thank you.
Now, you gave a presentation today about patients who have hypotension and heart failure. Yeah. Tell the audience a little bit about this.
If we look at all admissions for heart failure in the United States, approximately 5 to 10% have a blood pressure below 100 at time of admission. Often those patients require an inotrope, realizing that at this point in time we don't have safe and effective inotropes, but often physician has nothing at disposal to improve cardiac output. So we recently characterized this group. Obviously, they present with a pressure less than 110. They have an in-hospital mortality can be as high as 5 to 10%. They have a post-discharge mortality as high as 15% within 60 to 90 days. And the readmission rate is about 35 to 40%. So although many improve during hospitalization, their event rate can be as high as 60%, 60,
wow,
at 60 to 90 days post-discharge.
So lesson one is this is a very bad prognostic sign.
Yeah.
Is it always due to low output?
That's a very good question. You have to be a good clinician and at the bedside distinguish between low blood pressure that was there maybe for a week or two or a month compared to low blood pressure because of an acute drop in cardiac output. Because there are many patients with chronic heart failure who have a blood pressure of 90. The difference is that in a chronic setting, they don't have dyspnea, they have a high sympathetic tone, but when the patient is being admitted, it's because he or she has signs of heart failure, they have a high sympathetic tone, a very high wedge pressure, and in spite of having high filling pressure, high sympathetic tone, they still cannot achieve a higher blood pressure. Matter of fact, if you look at all hospitalizations for heart failure, approximately 50% are hypertensive. It's a reactive hypertension because within a diuretic, within an hour, the blood pressure is normalizing.
Down, right.
So having a low blood pressure like 100 at the time of admission, when you have significant signs and symptoms of heart failure, is not a good sign. So prognostically, it's a bad sign. As you pointed out, not everybody has a low cardiac output. Again, you have to touch their hands, and if they are warm and perfused and full pulse, they have a low blood pressure. But many of those patients did have a low cardiac output. They are cold, clammy, they have less dyspnea and more fatigue. And per guidelines, often they require an inotrope, realizing that dobutamine and dopamine and mirinone can improve hemodynamics but at the expense of causing injury, particularly in patients with coronary artery disease. In fact, in the REVIVE-2 trial, an uptime trial, a decrease in blood pressure in response to dobutamine or mirinone caused a higher mortality post-discharge. The problem that we have is that often those so-called inotropes will also decrease the blood pressure.
Decrease the
blood pressure. In a way, the so-called inotrope like dobutamine can be tested to see if the cardiac output is low. If the blood pressure is low because of a low cardiac output, dobutamine often may increase the blood pressure. Mm-hmm. But if you dobutamine to someone with normal cardiac output, you see more vasodilatation. So in a way, you can decide at the bedside when indeed the cardiac output is low. Now, if dobutamine is increasing the blood pressure from 90 to 110 and it's not increasing the heart rate, then probably it is okay, particularly in patients without CAD. So you really have to look if they have CAD or not CAD. You also have to see how they respond to those inotropes. Ideally, they should not drop further the blood pressure. They should not increase in the heart rate. But it's a problem group patients because they have a poor prognosis, but they don't have end stage. So maybe some have viable tissue. So the question is, how can you bridge those patients to more definitive therapy? Because it's difficult to start a beta blocker, it's difficult to start an ACE inhibitor, it's difficult to start an MR antagonist. So I guess we need some new agents that can safely improve hemodynamics without causing injury, particularly in patients with coronary artery disease.
Patients present with evidence of heart failure, they're short of breath. This one's hypotensive. Typically, we're pouring on the diuretics, starting a little ACE inhibitor. But you're saying this group has to be managed a little bit differently.
You have to be a clinician and at the bedside decide who has a low output with low blood pressure, or we have a higher blood pressure with low cardiac output.
Yes.
So the clinical assessment, I think, is very important. We're not going to insert a PA line on every patient with hypotension. However, occasionally, when clinically things do not make any sense, one should have a low threshold to have a PA line.
Okay.
And further clarify more about the wedge, PA pressure, and the cardiac output. So if you try your best and your best doesn't work, and hospitals that are equipped, because let's keep in mind that 20 years ago, every CCU was an expert in a PA line.
Right.
Because 20 years ago, every other patient had the PA line. Nowadays,
Not true.
we no longer have the structure, so inserting a PA line is kind of an experiment. So it's better not to get any data than to get erroneous data.
Right.
But there are times that a PA line is still indicated for those patients, and they should be tailored or managed based on cardiac output, wedge pressure, and PA pressure.
So is the difference in our approach then to these patients? What else can we do for these folks?
This group presenting with relatively low blood pressure has to be fully characterized.
Yes.
And divide them, as you pointed out before, in patients who indeed had a low cardiac output or patients who are hypotensive without low cardiac output. That would be in the first step.
Okay.
If they have relative hypotension, they have a high filling pressure, and the cardiac output is okay, a diuretic and nitrates may not be the worst thing you can do to them.
Okay.
But I'll have a high threshold to use dobutamine or dopamine in those patients. On the other hand, if truly they have a low cardiac output, even if I don't like dobutamine, even if I don't like Mirinon, sometimes you're forced to use those agents because the blood pressure is 70 or 80, the patient is short of breath, it's weak and so on, and has no urine output.
Is there any role for digoxin in these patients?
Maybe I'm biased because I've been doing so much research in DIGE, but I can tell you, I did those studies while I was at Ford. Those were published in Circulation and JACC, and we show this is not double-blind data, so you have to be very careful to interpret. But in those studies, we show in the following, that when look at patients admitted for heart failure, those people were instrumental. We've seen a major increase, a 40% increase in cardiac index, 30% decrease in wedge, a significant decrease in heart rate, an increase in systolic but not diastolic blood pressure, and improvement in neurohumoral profile. Mm-hmm. So at least from a hemodynamic point of view, DIGE, it's a good agent, and doesn't have to be given IV.
Right.
If anything, if you get IV, give it slowly, because if you give it rapidly, you get vasoconstriction. So it can make the patient worse. So it's nothing wrong, although we haven't done any outcome study.
Right. It's
nothing wrong to consider digoxin. I'll be conservative and use the PO rather than IV.
And what kind of dose?
I think the same thing like we did in those two studies. You start with 0.5 and you don't go above 1. You use 0.5 PO, you wait another 4 to 6 hours, give another 0.25. So a total of 0.75 PO, and then you start with the maintenance dose. Right. Obviously, if you have renal insufficiency, amiodarone or other things, or quinidine that's not being used now, you're not going to use it. Now, another reason to use digoxin is because many of those patients, it's 40%, have atrial fibrillation.
Sure.
Not only do they have atrial fibrillation, but they have a rapid response. And often dobutamine, dopamine, and Mirinon will further increase the AV node conduction. So if anything, those three agents are relatively contraindicated in atrial fibrillation because it can worsen the hemodynamic by increasing the rate, the ventricular rate.
Right. So I think you've taught us a lot here today. You've told us, one, that when we see this, first we've got to do a good clinical examination to determine why the blood pressure is low. That sometimes intravenous agents can be used to raise the blood pressure, at least temporarily. In other patients, we can treat in a normal way. And then last, although we don't see digoxin used very much, for one group of patients, this may be a very useful drug.
Should be considered.
I want to thank you very much for sharing this with the ACCEL audience.
Thank you. It's been a pleasure.